Hello everyone. So let's start with the first doubt that was asked. Which of the following accessory ligaments of the TMJ is likely to influence mandibular movement? Now we all know our TMJ is made up of a number of ligaments, the most important one being the TMJ capsule and the lateral ligament, which is the thickening or the reinforced part of the TMJ capsule, also known as the temporomandibular ligament. So these are definitely the intrinsic and most important ligaments of the TMJ. Along with that, there are two extrinsic ligaments, the sphenomandibular and the stylomandibular ligament. So there's no ligament called pterygomandibular ligament, so we can eliminate option C and D. Now coming to the sphenomandibular ligament, it originates from the spine of sphenoid, and as you can see, it inserts on the inner or the medial surface of the ramus of the mandible at a point called the lingula. So this is our sphenomandibular ligament. Now what does this ligament do? Through its attachment, basically it's going to play a very important role in limiting the movement of the mandible in the inferior direction. So normally this ligament is relaxed, but when your mandible goes downwards, that is when you open your mouth, the ligament becomes taut or stretched and prevents excessive inferior or excessive mouth opening, which can cause strain on the TMJ. So it's an inferior check ligament. Now coming to our stylomandibular ligament, it's going to originate from the styloid process of the mandible, of the temporal bone, and insert into the angle of the mandible. Now this styloid ligament is believed to be a thickening of the parotid fascia. So this stylomandibular ligament is going to basically limit excessive protrusion of the jaw or forward movement of the mandible. We all know our lateral pterygoid, which attaches somewhere here. It's a very powerful protruser of the mandible. So to check that and prevent excessive protrusion, the stylomandibular ligament comes into play. So sphenomandibular is going to prevent excessive inferior movement and stylomandibular is going to prevent excessive protrusion. So both these ligaments, through their attachments in the cranium and mandible, are going to act like a swing. So it's going to support the mandible and in the various movements and also act as check ligaments of the mandible. So technically speaking, both of them, option A and B, are equally important in influencing mandibular movement, but I will still say that stylomandibular could be slightly more important if you have to answer one, because excessive protrusion of the mandible needs to be kept in check because the lateral pterygoid is a very powerful protruser. So in this you can answer it as option B, but technically both A and B are important ligaments which influence mandibular movement. So you can appreciate that in this diagram. Now coming to the next question, IJV or the internal jugular vein is a continuation of. So a student had a doubt between option A, common facial, and C, sigmoid sinus. This is very important to remember. The sigmoid sinus, which is a dural venous sinus, a sinus in the brain, directly comes downwards, and just at the termination, it will form a dilatation called the superior bulb, and just from that will continue our internal jugular vein. So it will first form within the jugular foramen as a direct continuation of sigmoid sinus, exit jugular foramen along with the internal carotid artery, and it will then travel almost vertically downwards, as we all know, within the carotid sheath. Once it travels vertically downwards, just at its termination, it will form another dilatation called the inferior bulb of the IJV, and then it will join with the subclavian vein to form the brachiocephalic vein. So it is a continuation of sigmoid sinus. Now the next question is basal lamina of blood vessels in the CNS. Now for this, we need to remember the important cells present in the CNS. Along with the neurons, we have some neuroglial cells as well. So we have the microglia, we have astrocytes, and the oligodendrocytes. So the other cells like the oligodendrocytes and microglia, they are very important to form the myelin sheath of the nerves and also to act as phagocytes. Now our astrocytes, a very important cell of our CNS, basically it will serve as a control over the blood-brain barrier, or it will prevent excessive transmission or check the transmission of substances to and from the blood-brain barrier. Now it is also called as a tile of the CNS. because it will basically lay the foundation or the structural framework of all the important structures in the CNS. So you can see clearly in this diagram, these astrocytes have something called as end feet, large end feet, and these end feet will basically form the basal lamina or the covering of the blood vessels. So the cerebral blood vessels or the cerebral vasculature is given integrity and strength by the end feet of these astrocytes. You can see how they cover the blood vessels. The endothelial cells are only going to line it, but the basal lamina is formed by the astrocytes. So option D is the correct answer here. Now the next question is, the first costochondrial joint is. Now very important to keep in mind, what is this costochondrial joint? Now we all know our ribs are going to have an attachment on the sternum, but they do not attach directly on the sternum. They will attach via a cartilage called as the costal cartilage. So first it will attach to the costal cartilage, which in turn will attach to the sternum. So the joint which is present between the end of the rib and the costal cartilage is called the costochondrial joint, as you can see pointed in this diagram. Now the first to sixth, along the first few ribs, the joint is going to be something called a synchondrosis, okay, or synarthrosis. Now synchondrosis basically means a hyaline cartilaginous or a primary cartilaginous joint. So the first few ribs will be a synchondrosis, and since this joint is immobile, it is called a synarthrosis. So if the joint is slightly mobile, it will be called amphiarthrosis, and completely mobile will be diarthrosis. But here this joint is completely immobile, so it is a synchondrosis joint, which is a synarthrosis or an immobile joint. When we talk about the 6th to 9th ribs, it will be a synovial joint, and the 9th and 10th ribs will be a fibrous joint. So the lower joints will be synovial and fibrous in nature, and since they've asked the first costochondrial joint, it will be a synchondrosis and a synarthrosis. So they can sometimes also put this option. So this is also correct. It is a synchondrosis, and all these joints are synarthrosis or immobile joints. Now the next question is, Bishit syndrome is associated with which organism? Now Bishit syndrome is basically a chronic inflammatory condition in which there is inflammation, systemic inflammation or vasculitis of all the important blood vessels in the body. So it's a generalized systemic vasculitis, and commonly it is also called a silk route disease, because in the olden times there used to be a silk route or a route which extended from Asia to the Mediterranean Sea, where a lot of silk trading used to happen, and very commonly along this route it used to occur. So it's also called the silk route disease, and characteristically, as you all have read about it, there will be recurrent oral and genital ulcerations, uveitis and systemic vasculitis, and very commonly individuals who have this HLA-B51, and these individuals will have more predisposition to developing this disease. So this is important to keep in mind. Now when the samples were taken from these cases of Behçet's disease, most commonly they have noted this important organism called as Streptococcus sanguis and Helicobacter pylori. So they found a lot of antibodies to this H. pylori and lot of S. sanguinis, which was isolated. So the most common organism associated with Behçet's in this would be Streptococcus sanguis. You must have read about this when we studied about endocarditis. So this is a very important organism which is linked to causing endocarditis. So Streptococcus sanguis is very important, and most commonly Behçet's syndrome is associated with this along with H. pylori. Now coming to the next question, blood supply to coronoid process of mandible. Now to understand the answer to this question, just keep in mind this diagram. So now you can see this is a cut mandible. The coronoid is missing, but you know it's going to be somewhere here, the coronoid. Now look at all the options. Now our inferior alveolar artery, as we know, it's a branch of maxillary artery, and it's going to enter the mandible through the mandibular foramen and pass through the mandible body and end at mental foramen. So it's not really anywhere near the coronoid. It's going to enter the mandible before that. So we can eliminate this one. Then the facial artery, we know it travels from the angle of the mandible and travels anteriorly and terminates in the medial portion of the eyelid. So it's going away from the coronoid. So we can eliminate this. Now we all know our coronoid process is going to have the insertion or the attachment of the temporalis muscle. So this temporalis muscle is supplied by two important arteries, that is the deep temporal arteries. So these deep temporal arteries, which are given off from the maxillary artery, are supplying our temporalis. So they are going to be just right where the coronoid process is. So I would say, according to this diagram and knowing that the temporalis attaches onto the coronoid, I would say that the deep temporal arteries are mainly going to be supplying our coronoid process of the mandible. Now, I was asked a question about what is the embryology of the thyroid gland. Now, two things to keep in mind. First thing is that our thyroid gland is going to form at the base of the tongue and then migrate downwards and end in the neck. This is something you all are aware of. So where does it arise from? Now we all know, in this diagram we can see the anterior two-third of tongue is formed by these three structures, the lingual swellings and the tuberculum impar, and the posterior third of the tongue is formed by the hypobranchial eminence, and at the junction of the anterior two-third and posterior one-third we have the foramen cecum. Now from this foramen cecum at the junction of anterior two-third and posterior one-third, there will be something called a thyroid diverticulum. Now this is formed in the third week of gestation by proliferation of many endodermal cells which is arising from the foramen cecum on the floor of the primitive pharynx. So what you need to remember in this is arises from the thyroid diverticulum at the foramen cecum by proliferation of endoderm. So thyroid is formed from endoderm, an important MCQ question. Now these cells will proliferate and form the thyroid gland. Initially it will be present at the base of the tongue, and then this thyroid gland will travel downwards via the thyroglossal duct and travel and reach its final position in the neck, and by 5th week it will divide into the the two right and left lobes. So this process, as you can see, happens between the first and the second pharyngeal pouches, the first one and the second one. So important things is first to second pouches, between the first and the second pouches, at the 3rd week it starts developing from the diverticulum and it is originated from the endoderm. So these 4 to 5 points keep in mind, and initially formed at the tongue base and then it travels downwards to reach its final position in the neck. So this thyroglossal duct will then later on it will disappear, but sometimes persistence of this duct can put the person at risk for developing thyroglossal cysts. So this is about the embryology of thyroid gland. Now one more question was asked, that what is stellate ganglion? Is it the same as cervicothoracic ganglion? Yes, they are one and the same thing. Now this is the following, you can see this image. It's a diagram of our cervical spine, as you can see here. Now this C spine, we all know, is supplied by the cervical sympathetic plexus, and there are 3 important ganglia: the superior, the middle and the inferior cervical ganglion. Now this inferior cervical ganglion, in 80% of the patients, it's going to fuse with the first thoracic ganglion. So inferior cervical fuses with the first thoracic ganglion, which is going to be present below it. So what happens, the inferior cervical and the first thoracic ganglion will fuse together. So since it's a fusion of the C spine, the ganglia of the C spine and the ganglia of the thoracic spine, it will be called the cervicothoracic ganglion. Now this ganglion is polygonal or star shaped, and hence it is also called the stellate ganglion. So to answer your question, it is one and the same thing, the cervicothoracic and the stellate ganglion. And since it's at the bottom or at the inferior part of the spine, it will be located at around C7, at the level of C7, and this ganglion will be present just at the neck of the first rib, and below the or beneath, as you can see, the subclavian artery. So two things to keep in mind. It's at C7 beneath subclavian artery, just at the neck of the first strip, and it will be covered by the prevertebral fascia. Now, why is this ganglion important clinically? Because nowadays, a lot of conditions we know there are, you must have read in general surgery about the sympathetic pain, regional pain syndromes, or Raynaud syndrome. So these are all pains which occur due to the sympathetic plexus involvement. So in cases of patients who are suffering from severe Raynaud syndrome, hyperhidrosis, patients who are suffering from hot flashes and sweating due to menopause, or severe pain after treatment of breast cancer, so any kind of sympathetic pain which is sympathetic, which you have read in general surgery like Raynaud's. So all of these pains, if some surgeons advocate for cutting the stellate ganglion for management of these kinds of sympathetic pains. And very popularly nowadays, this stellate ganglion blocks or injection of local anesthesia around the stellate ganglion is being popularly done for treatment of war veterans who are suffering from PTSD. So it is believed that it will provide some relief of symptoms. So that's probably why this MCQ is asked. Nowadays, very popularly, it's being used for patients suffering from post-traumatic stress disorder, PTSD. So local anesthetic can be injected around the stellate ganglion. So I hope you understood. So it is basically one and the same thing, the cervicothoracic, which is fusion of the inferior cervical ganglion with the first thoracic ganglion.